Hello, everyone, and welcome. Today, we'll be diving into ischemic heart disease and conduction disorders. This presentation is brought to you by Newton TV, so get ready to study smart. Let's start with a quick review of the heart's anatomy. This diagram illustrates the heart's external structure and the three tissue layers: the epicardium, myocardium, and endocardium. Understanding these layers is crucial for grasping the pathophysiology of heart diseases. Now let's talk about circulation, specifically coronary circulation. We'll cover the right and left coronary arteries, including the LAD, or left anterior descending artery. Remember that exercise increases coronary collateral vessels, which is beneficial for heart health. Here's a more detailed view of the coronary arteries. Take note of the aortic arch, left main coronary artery, circumflex artery, LAD, right coronary artery, and posterior artery. These are the major vessels supplying blood to the heart muscle. Moving on to the heart structures, let's review the four chambers. The right atrium receives blood from the vena cava and coronary sinus, while the right ventricle pumps blood to the lungs. The left atrium receives blood from the pulmonary veins, and the left ventricle pumps blood to the body. This diagram provides a visual representation of the heart's chambers and valves. Notice the tricuspid valve between the right atrium and ventricle, the pulmonary valve above the right atrium, the mitral valve between the left atrium and ventricle, and the aortic valve. Understanding their location is key to understanding blood flow. This image illustrates the pulmonary and systemic circuits of the circulatory system. The right side of the heart handles oxygen-poor blood, while the left side handles oxygen-rich blood. Follow the flow from the right ventricle to the lungs and back to the left atrium, then from the left ventricle to the body and back to the right atrium. Let's shift our focus to conduction. The heart's electrical conduction system is responsible for coordinating its contractions. We'll be discussing the sinoatrial node, SA node, AV node, bundle of His, bundle branches, and Purkinje fibers. This diagram shows the electrical conduction system within the heart. The SA node initiates the electrical impulse, which then travels through the AV node, bundle of His, bundle branches, and finally, the Purkinje fibers. This coordinated pathway ensures efficient heart contractions. Here's a look at the action potential in a cardiac muscle cell. Notice the different phases: depolarization, phase 0, brief repolarization, phase 1, plateau, phase 2, repolarization, phase 3, and resting potential, phase 4. Understanding these phases is crucial for understanding how the heart contracts. This image correlates the heart's electrical activity with the ECG. The P wave represents atrial depolarization, the QRS complex represents ventricular depolarization, and the T wave represents ventricular repolarization. This is a fundamental concept for interpreting ECGs. Now, let's discuss the refractory period of the heart. During the absolute refractory period, cells cannot be re-stimulated. This is essential for allowing the heart to relax, fill with blood, and preventing fatal arrhythmias. Moving on to dysrhythmias, which are disruptions in the heart's electrical signal. These can be supraventricular, originating in the SA node, atria, or AV node, or ventricular, originating in the bundle of His, bundle branches, Purkinje fibers, or ventricle muscle. We'll also touch on tachyarrhythmias and bradyarrhythmias. This diagram categorizes dysrhythmias into blocks and ectopic pacemakers. Blocks most commonly occur at the AV node, while ectopic pacemakers originate outside the normal conduction pathway, such as in premature ventricular contractions, PVCs. This is a standard ECG diagram. Familiarize yourself with the P wave, QRS complex, T wave, and U wave, as well as the PR interval, QRS interval, ST segment, and QT interval. Understanding these components is essential for interpreting ECGs. Let's discuss acute coronary syndrome, ACS. ACS is broadly classified into unstable angina and myocardial infarction, MI. MI is further divided into STEMI, ST elevation MI, and NSTEMI, non-ST elevation MI. Now, let's focus on angina. Angina pectoris is chest pain caused by myocardial ischemia. It can be stable, with consistent chronic pain relieved by nitroglycerin, or unstable, which is a new episode or increased severity and a medical emergency. This diagram explains the causes of angina pectoris. Myocardial ischemia can result from a blood clot, atherosclerotic plaque, or coronary artery vasospasm, also known as Prinzmetal's or variant angina. Ischemia leads to lactic acid accumulation, resulting in pain. This image highlights the potential pain locations associated with angina. While chest pain is the primary symptom, pain can radiate to the neck, jaw, upper abdomen, shoulders, and arms. It's important to consider gender differences in angina presentation. Anginal equivalents, such as dyspnea, feeling faint, epigastric pain, dizziness, and extreme fatigue, may be more common in women. Studies show that MIs may be missed in women, and they are often treated less aggressively than men. Let's discuss risk factors and signs and symptoms of angina and CAD. Risk factors include smoking, diabetes, hypercholesterolemia, and metabolic syndrome. Symptoms include chest pain brought on by exertion, radiating pain, and Levin's sign, where the patient clenches their fist over their sternum. Here are some diagnostic tests for angina and CAD. Cardiac enzymes, particularly cardiac troponin, are confirmatory for MI. ECGs can show ST elevation but are not confirmatory. Other tests include blood lipids, blood pressure, HS-CRP, chest X-ray, and calcium computed tomography, CT. More diagnostic methods include intravascular coronary angiography, which is the gold standard but carries a risk of plaque rupture. Non-invasive coronary computed tomographic angiography, CCTA, has a decreased risk of plaque rupture. A graded exercise stress test can help determine areas of injury under stress. Let's discuss non-surgical treatment options. The goals are to relieve symptoms, reduce CAD progression, and prevent MI. Therapeutic interventions include oxygen, nitrates, aspirin, beta blockers, calcium antagonists, and ACE inhibitors. Remember, if pain isn't relieved after 3 doses of medication within 10 minutes, further action is needed. Now, let's move on to endovascular treatments. Percutaneous transluminal coronary angioplasty, PCTA, uses a balloon to push plaque against the arterial wall. Atherectomy uses a blade to reduce plaque. Stents maintain an open vessel, and drug-eluting stents are often used. This diagram illustrates the process of stent insertion. A catheter with a balloon and a closed stent is inserted into the artery. The balloon is then inflated, expanding the stent and compressing the plaque. Finally, the stent remains in place, widening the artery. Let's discuss surgical treatment options. Coronary artery bypass graft, CABG, creates new roots around occlusions. The saphenous vein of the leg is often used. Triple, quadruple, or quintuple bypasses may be performed depending on the extent of the disease. This diagram shows a coronary artery bypass. A new artery is grafted onto the heart to bypass the blockage, restoring blood flow to the heart muscle. Now let's talk about myocardial infarction, MI. MI results from prolonged ischemia leading to irreversible damage. This can be caused by blood flow obstruction or when myocardial oxygen demand exceeds supply. Delayed request for medical help reduces survival. This diagram illustrates a myocardial infarction. Notice the healthy muscle and the dying muscle. The close-up view shows an artery with a cholesterol plaque and a blood clot, causing the blockage. Let's discuss the characteristics of MI damage. Factors include location, length of time, and available collateral circulation. Greater than 30 minutes of ischemia causes irreversible damage. Necrotic cells release cellular contents, such as cardiac troponin, which can be detected in blood tests. This diagram shows the zones of infarction, injury, and ischemia. The area of infarct is surrounded by an area of injury where some cells may recover. Understanding these zones is important for understanding the extent of damage. Here are some signs and symptoms of MI. These include crushing chest pain, Levin's sign, pain radiating to the shoulder, jaw or down the left arm, sweating, nausea, anxiety, and anginal equivalents. For MI diagnosis, cardiac troponin is a key marker. ECGs cannot confirm MI, but blood tests for CPK-MB and cardiac troponin can. Echocardiograms and radionuclide myocardial perfusion can also be used. Remember the difference between STEMI and NSTEMI. Treatment for MI includes MONA, morphine, oxygen, nitrates, and antiplatelet, aspirin. Percutaneous coronary intervention, PCI, and coronary artery bypass graft, CABG, are also options. Thrombolytic agents like TPA can be used, but there's a risk of bleeding. Other treatments include anticoagulants, antiplatelet medications, beta blockers, and calcium channel antagonists. Stable angina or chronic CAD is characterized by recurrent chest pain and transient myocardial ischemia. At least one coronary artery is typically 70% occluded. Patients often self-medicate with nitrates. Remember that nitrates should not be prescribed for those taking phosphodiesterase 5 inhibitors due to the risk of severe hypotension. Let's move on to infectious endocarditis, IE. IE is normally bacterial, often caused by Staphylococcus aureus, and it damages valves. Risk factors include prosthetic valves, pacemakers, intravascular devices, and IV drug usage. Vegetation develops on the valve, and fragments can break off and enter the bloodstream as septic emboli. This diagram shows vegetations on the valves in endocarditis. These vegetations can become septic emboli, leading to serious complications. IE can be acute or subacute. A new or worsening heart murmur is an important sign. Diagnosis is based on labs and echocardiographic findings. 3 blood cultures drawn 12 hours apart is the preferred method. Treatment involves IV antibiotics for 6 weeks or longer. Now let's discuss myocarditis, also known as inflammatory cardiomyopathy. It can range from mild to lethal. Common causes include viruses such as influenza, herpes virus, hepatitis, and COVID. Symptoms may include fever, myalgia, arthralgia, and palpitations. A pericardial friction rub and S3 gallop may be present. For myocarditis diagnosis, labs such as CBC, ESR, and CRP are helpful. Cardiac troponin may be elevated. Viral antibody titers can also be checked. Treatment focuses on reducing myocardial workload and treating the underlying etiology. Activity is restricted for 6 months or more, and ACE inhibitors or inotropic agents may be necessary. Let's discuss pericarditis, which is the inflammation of the pericardium and epicardium. It can cause pericardial effusion, which is fluid surrounding the heart, and cardiac tamponade, which is fluid accumulation that compresses the heart. Acute pericarditis can mimic MI and may occur post-MI. Dressler's syndrome is a specific form of pericarditis after MI. This image compares a normal heart to a heart with pericardial effusion. Notice the fluid buildup around the heart in the heart with pericardial effusion. This diagram illustrates cardiac tamponade. Fluid buildup within the pericardial sac compresses the heart, impairing its ability to pump effectively. Pericarditis presents with chest pain, fever, and a pericardial friction rub. The pain worsens with deep breathing. Beck's triad includes hypotension, jugular vein distension, and muffled heart sounds. Pulsus paradoxus is a decrease in SBP by 10 mmHg or more with inspiration. Diagnosis can be made with an echocardiogram or cardiac MRI. Thank you for watching. Please subscribe, like, and share for more content from Newton TV. We hope this presentation has been helpful in your studies.